Hit the subscribe button or visit us at auau.auanet.org.
Hello, and welcome to Live from AUA 2022, Highlights in Overactive Bladder. We strive to offer educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. We thank you for joining us. Before we get started, we'd like to go over a few items. I'd like to extend a special thank you to our course director, Dr. David Ginsburg, for his tremendous efforts to plan this activity. We thank you for your dedication and commitment to urologic education. Thank you as well to our distinguished faculty, Drs. Ann Cameron, Sarah Lenher, and Eric Rovner for their time, talent, and expertise. The AUA is accredited by the ACCME and designates this enduring activity for a maximum of 1 AMA PRA Category 1 credit. The AUA is not accredited to offer credit to participants who are not MDs or DOs. However, the AUA will issue documentation of participation that states that the activity was certified for AMA PRA Category 1 credit. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view faculty, education council, and COI review workgroup disclosures. The AUA would like to thank Urovant Sciences, Inc. for providing an independent educational grant in support of this activity. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. Thank you for attending Live from AUA 2022. I will now turn the program over to Dr. Ginsburg.
Thank you so much, Helen. And thank you all for joining us today at Live from AUA 2022 to talk about currently available agents for overactive bladder, as well as third-line therapies and the current data regarding outcomes to facilitate proper patient counseling. My name is Dr. David Ginsburg. I'm a professor of clinical urology and director of FPMRS at the USC Department of Urology in Los Angeles, and I am pleased to be your moderator for today's discussion. I'm here today with three outstanding faculty members. Dr. Ann Cameron is the James Monti Legacy Professor of Urology and Associate Chair of Safety and Quality at the University of Michigan. After completing her medical degree at the University of Ottawa and residency in urology at Dalhousie University, she came to the University of Michigan for a fellowship in female pelvic medicine and reconstructive surgery. Dr. Cameron remains at the university where she is an active clinician and participant in several research trials, including the NIDDK-funded LURN. Her clinical interests include complex incontinence, female urethral disease, and the care of patients with neurogenic bladder. She also has a strong interest in medical education and is the Associate Fellowship Director. Dr. Sarah Lenher is an Associate Professor of Urology at the University of Utah. She is a board-certified urologist who focuses on female incontinence and management of neurogenic and non-neurogenic bladder dysfunction. She received her medical degree from the University of Chicago and did her residency at the Leahy Clinic. She completed FPRMS fellowship training at the University of Michigan and has a master's in health services research with a long-term research goal to better understand management of patients with neurogenic bladder. Dr. Eric Rovner is a professor in the Department of Urology at the Medical University of South Carolina in Charleston, South Carolina. He is the director of the section of voiding dysfunction, female urology, and urodynamics in the department. He is a past president of SUFU, and his research interests include the study of voiding dysfunction, urinary incontinence, neurogenic bladder, and genitourinary reconstruction. Welcome, Drs. Cameron, Lenher, and Rovner. Okay, so why are we here today? It is estimated that up to 1 in 6 adults have overactive bladder. Symptoms of overactive bladder include urinary frequency, urinary urgency, and urgency urinary incontinence. And I just want to make a distinction between the urge to void, which is a normal sense of having to void, and urgency, which is that sudden and often uncomfortable for patients' need to feel like they have to use the restroom immediately. And we know that the quality of life of overactive bladder patients can be significantly impacted by these urinary symptoms, and that up to 70% of patients will experience some degree of improvement with the various treatments we have for overactive bladder. That's the good part. However, many patients don't get started on these treatments, which include options such as pelvic floor therapy and oral agents such as anticholinergics and beta-3 agonists. And if patients are started on therapy for overactive bladder, there can be a variety of issues such as persistence. It is well documented that the long-term continuation rate for oral overactive bladder therapy is suboptimal. There is also a concern that patient expectations may play a role in regard to this issue, and we're going to talk about that today, among other things. Also, the issue with side effects, primarily seen with the anticholinergic class of medications, and these side effects include problems such as dry mouth, constipation, and potential issues with cognition. And lastly, a concern is escalation of therapy. What does that mean? So if one therapy does not adequately improve a patient's symptoms, further therapy, other therapies are not always offered. Questions regarding this include what is the right therapy for each patient, and when is it time to try something additional or different, such as moving on to a third-tier therapy, such as, say, neuromodulation or botulinum toxin. So let's first start with diagnosing overactive bladder. So Dr. Cameron, we're going to put you up first. So the AUA SUFU Overactive Bladder Guidelines course discussed overactive bladder evaluation, and Dr. Goldman's instructional course, highly interactive case-based discussion of issues in female pelvic medicine, focused on streamlined methods to evaluate overactive bladder among several topics within the course curriculum. So I have a few questions for you. I'll go through them, then I'll let you go to town and answer everything. So what is the minimal evaluation required to diagnose overactive bladder? What additional tools will you use at times when initially evaluating someone with suspected overactive bladder, or possibly later after initial therapies have failed? So for example, do you use any questionnaires in your practice? And if you do, different kinds of questionnaires that we use. Is it one that's more focused on evaluating symptoms or more evaluating quality of life and the impact of quality of life? And if you do use these questionnaires, do you continue to use them when patients follow up to look for the response to therapy? And lastly, when, if ever, do you decide to use additional tools such as voiding diaries, evaluation of post-void residual uroflow, urodynamics, and cystoscopy?
All right. I'll try to answer all of those for you. So when you meet a patient and they have symptoms suggestive of overactive bladder or voiding concerns, I think you really need to start with a good history. The symptom that is the core of an overactive bladder diagnosis is urgency or urgency incontinence. So someone needs to have that symptom to be accurately diagnosed with overactive bladder. But it's also important to judge how this symptom started. What's the progression of their symptoms? Did it start all of a sudden, or is it something that's progressed over time? And if it's something that started all of a sudden, getting a history of the medical details surrounding that is also very important. Did they start a diuretic the first day that they had this urgency? So you really need to dive into the symptoms and the symptom progression. I think it's also important to get a good pelvic health history, parity, genitourinary surgery, any bothersome bulging, a UTI history. So much of my evaluation actually centers around just asking the patient about their symptoms, also getting a clear history of things that make their symptoms worse versus makes their symptoms better. A lot of overactive bladder patients will clearly describe triggering events. So running water, hearing the front door open, jingling their keys, that'll trigger an urgency episode. That's classic urgency and overactive bladder symptoms. But you also have to be more broad-minded when you're evaluating someone. You do have to rule out other conditions that can cause urgency that are not overactive bladder, because overactive bladder is these symptoms in the absence of other pathology. You have to rule out a urinary tract infection. A urinalysis is a great start. I always do a urinalysis on someone presenting with lower urinary tract symptoms, and that urinalysis can also screen for hematuria. So that's a bare minimum, as well as a post-void residual. I also, as a bare minimum, do a pelvic examination, either a female pelvic examination or a digital rectal exam, as well as a general neurological exam, seeing how well someone is able to move and walk, to screen for occult neurologic injury, which you also are screening for in your history. So you want to rule out things that are not overactive bladder, rule those out of your differential diagnosis, and then you're better able to make a diagnosis. So I think your other question was, what other testing modalities do you do beyond the basics? Because what I just covered was the basics, the bare minimum that you can use to diagnose overactive bladder. There's not always certainty after you do that history and physical exam. And so there are instances where more is needed. For example, if someone has microhematuria and lower urinary tract symptoms, they need a cystoscopy. They need a microhematuria workup. You have to rule out bladder malignancy. Carcinoma in situ can cause urgency symptoms. So that definitely needs to be ruled out. I often use symptom scores. Those are actually part of my basic evaluation. And I use the AUA symptom index score for both men and women. I also use an incontinence symptom index that covers stress and urge and bother and pad use. And I also like to use the either female or male Guppy score that covers questions surrounding interstitial cystitis type symptoms, because again, those are very overlapping symptoms. I don't think someone needs to use all of those surveys, but again, I use them all in my practice because I find them all to be very helpful, because I see a lot of people with overlapping symptoms. And again, those surveys can be extraordinarily helpful when you're following someone's treatment response. It's very difficult for anyone to remember symptoms historically. How much urgency did you have 3 months ago? How much frequency did you have 3 months ago? People don't remember. They remember worsenings and improvements, but having objective scores of how often they had nocturia is really, really helpful. Again, whenever there is uncertainty, I will also move on to other testing modalities. Very cheap and easy things include avoiding diarrhea, having the patient record what they drink, when they drink it, how much, and record their urine volume, their urgency and leakage for 3 consecutive days is really invaluable. If someone is complaining of nocturia in particular, you can calculate how much urine they're making at night and find out if they have nocturnal polyuria. Also, people sometimes have a hard time guesstimating their nocturia, guesstimating their frequency. They may say, I have nocturia times 5, but when they present you with a diarrhea, it might be a different number, because people tend to remember the worst. And Learn actually did some work in patients with LUTS and looked at voiding diarrheas in 1,000 individuals. And again, most people were pretty good at guesstimating their frequency and their nocturia, but people who had very severe reported nocturia actually didn't have as much nocturia as they thought. They were probably reporting their worst time. And again, it's important because then you have objective data surrounding that. Again, a uroflow can sometimes be helpful, particularly if someone has obstructive type symptoms, either a male or a female. But again, men have prostate, and there can be the confounding BPH diagnosis. So I often use a uroflow in my male patients because it's important to know how good their flow is. And if you're screening them for BPH, I'm also doing a digital rectal exam. And again, you progress through these more straightforward testing, and I often reserve urodynamic studies for treatment failures. It's pretty uncommon that I meet someone with urgency or urgency incontinence and proceed direct to testing. I would often do a trial of medication or physical therapy and conservative measures and have them assess that response before moving on to urodynamics. But there's always those people where something isn't right, something doesn't add up in the history, or you're concerned about other pathologies. And at that times I might move ahead earlier with urodynamics. But usually I do several treatments before moving on to urodynamics.
That's great. Thanks, Ann. I think you hit on some really important points. And I think one of the ones that is important is we see overactive bladder in both women and men. And don't just assume that all male LUTs are BPH. And I think your point about the diary and having what patients intake is important, because you'll see these patients that have frequency and they have 5 cups of coffee a day and a bunch of iced tea and orange juice and Dr. Pepper, and they're filling themselves up with caffeinated products, which that could be an easy fix that has nothing to do with medication. I mean, so it's a really nice, important point. Thank you.
And another thing go ahead, Eric.
I think I want to emphasize what Ann talked about with the diary, but also in the world of overactive bladder, we sometimes forget nocturia, and with the overactive bladder complex, a significant portion is nocturia, but then there are patients who really have nocturia as their most bothersome symptom. And to Ann's point about the importance of a diary, without a diary, you can't really cull out who's got nocturnal polyuria or even polydipsia as a contributing factor to their overactive bladder symptoms. So I think to tackle this condition effectively, I use a diary more often than I don't, even when I'm seeing the patient for the first time. So I find them to be extraordinarily helpful in my practice. And even though it's not part of the AUA guidelines as mandated at the initial evaluation, I find it incredibly helpful in my management of patients. And to use this simple statement that my patients, clinicians will criticize the diary as saying that their patients won't be compliant with a diary. I find that to be more often than not the case. Patients who invest in doing the diary and invest in their own health do actually complete the diary and are quite compliant. So I think a diary, in my estimation, is a critical part of what we do in avoiding dysfunction, and especially overactive bladder.
Right. And for those, I think for those folks that have trouble getting their patients to do a diary, it's worth it just to spend some time educating your nurses and let them do the education for the patients. We don't want to spend that our nurses do that in our office. And to your point, and I think I would assume for all of us, when a patient comes in, their primary complaint is nocturia and not really urgency, and everything else is fine, none of us are giving them medication. They're going home with the instruction to do a diary, and we'll see you back with the diary because you're probably having nocturnal polyuria or you're drinking too much before you go to bed. And it's that simple. So let's move on. On Friday, there were several debates on Friday during the SUFU session that focused on optimal oral therapy and third-line therapy for overactive bladder. So Dr. Linder, I'm going to give you, just like with Ann, a list of questions, and I'll let you go and answer those. So what is the difference between behavioral therapy and pelvic floor physical therapy? And then, so we all love physical therapy. We're all sending our patients to do that all the time. None of us are trained as physical therapists. So how do you go about offering it to your patients? How do you choose which overactive bladder patients to offer behavioral therapy, physical therapy, or both? And do you think there are some patients that are more likely to do better or worse in regards to these therapies?
Thanks, David. I think that the question of behavioral therapy and the pelvic floor physical therapy and pelvic floor muscle training are really two important points of overactive bladder management that are just completely glossed over. And we also don't revisit these when we get farther along on treatment. So to kind of be basic, the behavioral therapy is really teaching an individual to improve their urinary symptoms by training the bladder to fill and then empty on a regular, predictable schedule. So if a patient has urgency at like 2 hours, I encourage them to go to the bathroom at 1 hour and 45 minutes or so. They all have devices in their pockets or something to bing or ding them. So there's ways around getting them to hopefully go to the bathroom before they get that urge to go to the bathroom. So we don't want their bladder to run their life. They need to take control of it, more like, telling your kid to go to the bathroom before they leave the house. And so then after about a week, if they can spend a week doing this time voiding without that irritating urgency, they can progressively increase the amount of time between voids by about 15 minutes a week until they can hold their bladder for a maximum of 2 to 3, maximum 4 hours, maybe, depending on how bad the overactive bladder is. And so that's kind of the timed voiding aspect of behavioral management. Along with that, then we also advise patients to drink the same volume of fluid, preferably water. I tell them water's their bladder's best friend. Drink that same volume every day. And so unless there's a significant medical issue, we recommend they not drink any more than 64 ounces of fluid a day, and try to kind of have that distribution of the fluid come in at a regular interval, and not just sit there and chug back like the huge container that a lot of people are walking around with for dietary purposes and things like that. This is really tricky to teach patients. I know a lot of large urology groups often have an OAB nurse or PA, APP champion that can facilitate OAB pathway treatments to remind patients about this. But I don't have such a person in my practice. But if I have a patient who I think can handle electronic reminders, I send them actually to the SUFU My Bladder app that's available both for Android and iPhone. It's in the App Store. It's called My Bladder, and it was developed by us SUFU members. And it's it has electronic resources about how to do behavioral therapy, how to do time voiding, and you can set alarms on there, and it can tell them, to void at, an hour and 45 minutes. And then they can progressively change that. There's actually an electronic bladder diary that's available in there that they can export to PDF, and reminders to stop fluids in the evening for their nocturia, those types of things that are available electronically. And so if I feel like I have somebody that can handle those types of reminders, I'll send them to that resource. I have it downloaded on my phone, and I show it to them, and they're like, oh, wow, okay. The other thing I do want to add into behavioral therapy is really recognizing constipation. If I could put billboards up on the interstate that said, have you pooped today, I would, but I don't think I'm allowed to. I think that recognizing what normal bowel regimen is really important for these patients. And I'll have many patients that come in that they poop regularly and they're only pooping once a week, or they're pooping 5 times a day, but it's small rabbit pellets. And so really recognizing that they need to have 1 to 2 soft bowel movements per day is regular and optimal for helping the bladder. And they get a little bit weirded out when they have these conversations with me when they want to talk about their bladder, but I actually redirect them to their issues with their bowels. So that's kind of the other part. For pelvic floor physical therapy independently, like at home, if I have somebody who I feel like is able to be coachable on a physical exam, I'll have them practice a Kegel squeeze. But really I find that's the limitation of pelvic floor physical therapy at home, or pelvic floor muscle exercises at home, is being able to just do that pelvic floor squeeze. It's very hard to teach patients to relax their pelvic floor on their own. And so that is the goal here, is to have them have better control of their bladder to prevent leakage with those exercises. But David, like you mentioned, we're not pelvic floor physical therapists. And so oftentimes, to get a patient to really coordinate their pelvic muscles with voiding, I do send them to pelvic floor physical therapists. I start that off by introducing the concept of a pelvic floor physical therapist. And I say, these are physical therapists that are trained to help you with your knee, but they have dedicated their entire practice to really helping people with issues in this pelvic area. And I point to the pelvic floor and everything. And I say that these are just really, they're great allies in helping overactive bladder management. I explained that for a first visit, oftentimes they'll only talk to the patient and get to know them. And then the second visit, they often will do a pelvic exam and really feel the muscles and help starting to coach the patient through these things. If I have somebody who's not comfortable with a pelvic exam, it's a big challenge. And sometimes it's a non-starter, or they really have to find the right therapist that they connect with. And they might need 2 or 3 visits before they're willing to let a physical exam happen. Regionally, I think there's a very large variation in pelvic floor physical therapists that we have available to us. In my region, I have a list for Utah, Wyoming, Idaho, Nevada, and Montana, because I'm sending people out to physical therapists in all those areas. Somebody might just have a physical therapy list for their area, but it's really beneficial to build a list of pelvic floor physical therapists and send the patients out and start getting feedback on those physical therapists, so you can actually offer up those resources as an actual list. Your next question, David, was how choosing, how are we going to navigate which one of these treatments we're going to offer? And so I really find that it depends on a stepwise indication and where those opportunities are. Some people are like, well, I'm perfect with my fluids and I'm perfect with my time voiding, but I still have to pee, 100 cc's every hour. And so there's not so much you can do with their fluid management if they're not drinking that much, and their time voiding can't be, there's only so often they can be in the bathroom. So you kind of have to identify where your big wins are going to be. And then, maybe pelvic floor physical therapy might be less of a lower yield, opportunity. Who does best with these different types of therapy? I think it really depends on cognition and motivation. Like Eric was mentioning, if you give somebody a bladder diary and they do it, they're probably a really highly motivated patient, and they might be very successful with next line therapies and doing their pelvic floor physical therapy. But if they're just kind of doing it in the waiting room, which many of our patients do, they fill out that bladder diary in the waiting room, it's not going to be, they might not be as dedicated to certain types of really intensive treatments that they need to do on their own, like physical therapy, time voiding, things like that.
Great. Thanks, Sarah. I think your comment about bowels is very important. And it's also important, we're going to talk about this shortly, is that some of the medications that we are giving for overactive bladder actually make the problems with the bowels worse, which then is just potentially exacerbating the problem.
Just to add one more thing, Sarah, I live in the 7th fattest state in the United States. Do you counsel patients on weight loss as well? I don't think that's as big a problem in Utah as it is in South Carolina.
It's not as big of a deal out here, but you're right. Recognizing that, and I have a treatment pathway that I was given by Una Lee many years ago, and really talks about those first line treatments, also along with smoking and other bladder irritants that are less prevalent for me in Utah. We have a low tobacco and low caffeine usage, although Red Bull is pretty popular.
All right, so before we move on to oral therapy, one last pelvic floor therapy question. So Anne, in your instructional course titled Managing Patients with Complex Voiding Dysfunction, was the use of pelvic floor therapy in patients with neurogenic lower urinary tract dysfunction discussed? And any thoughts on which patients with neurogenic bladder may actually benefit from pelvic floor therapy?
Sure, good question. And again, we don't often think of the neurogenic lower urinary tract dysfunction patient as benefiting from pelvic floor physical therapy, but there are certainly patients who do. Those patients who void volitionally, your multiple sclerosis patient, your post-stroke patient, your Parkinson's patient having OAB symptoms can certainly get a ton of benefit. And physical therapists don't just teach pelvic floor exercises. They are trained in teaching time voiding. They are trained in teaching fluid management and the behavioral therapy. So they do multimodal therapy, and they do a really good job. The NLETS guideline also does actually recommend that people may offer pelvic floor physical therapy to these specific groups, and they can get a lot of benefit if they're motivated to do it. That's often my litmus test. If someone is motivated to do pelvic floor physical therapy, they're probably going to do great.
Great, thank you. So let's transition over to oral therapies. So Eric, you have an instructional course with Doctors Alan Reen and Chris Chappell, which is Contemporary Pharmacotherapy for OAB 2022, Monotherapy and Combined Pharmacotherapy to Optimize Treatment. That really, it's a fantastic course, and it covers the gamut of pharmacotherapy for overactive bladder. One of the course objectives is to define the similarities and differences between the various oral pharmacotherapies for overactive bladder. So Eric, can you speak to how these oral therapies are similar? Do you expect to see differences in efficacy between the various therapies, or is it really more patient dependent?
Yeah, good question, David. I want to thank my co-course leaders, Doctors Ween and Chappell, because some of what I'm going to say really comes from the talks that they gave. I every year that we've given this talk, I always learn something from both Chris and Alan. It's a terrific course, so I recommend it to everybody at AUA. Anyway, similarities are, we'll start off at an AUA level. Both classes of agents, beta-3s and antimuscarinics, are recommended by the OAB, SUFU AUA OAB guidelines. You know, the efficacy between the agents seems to be rather similar, even when Alan does his placebo drug ratios. All of the drugs seem to have the same ratio of efficacy versus placebo. That is, when you correct for the placebo response, the efficacy seems to be about the same across the antimuscarinics and similarly across the beta-3s. Some newer data that's emerging over the last several years in both classes of agents is actually under the mechanism of action. So we look at antimuscarinics, and we traditionally have been taught about the efferent mechanisms of antimuscarinics. That is to say, reversible antagonists at the neuromuscular junction of acetylcholine as a mechanism of action. And for beta-3s, we're taught about a different mechanism of action, smooth muscle relaxation, working in a very similar mechanism to norepinephrine. However, it's emerging evidence, both in vitro and animal model and even clinically, it would appear that these drugs both work, at least in part, by an afferent mechanism, that is on the sensory side. And that's really interesting. Now, they work somewhat differently, but to qualify it, we think about OAB as a problem of filling and storage, and yet if you hypothesize that these drugs work on a efferent side, people are contracting their bladders less than 1% of the day, but their filling and storage is the majority of the day, even if you're urinating 20 times a day in overactive bladder. And the cardinal symptom of overactive bladder is urgency, which is not an efferent phenomenon. It's an afferent phenomenon. And there is some data now suggesting that antimuscarinics may have afferent activity, but now there's emerging data presented at this meeting about beta-3s actually also having afferent mechanisms, possibly through a acetylcholine pathway, but nevertheless an afferent mechanism. So both drugs seem to work through, at least in part, an afferent mechanism, even though they work by completely different mechanisms with respect to the receptors that they affect. And if we look at similarities between each of the two classes, that is antimuscarinics and beta-3s, let's start with the beta-3s. Even though there's no direct comparisons between the two currently available beta-3s in the United States, sort of a placebo drug ratio would suggest that the efficacy between the two agents is actually fairly similar with respect to urgency reduction, frequency reduction, and urgency incontinence reduction. And we could argue about subtle points on each of the studies. But I think from a global view, the drugs work fairly similarly. And the beta 3s, also some data from this meeting and also last year's meeting about compliance. The compliance, patient compliance with the beta 3s seems to be pretty good over the long term, and perhaps even a little bit better than the antimuscarinics, perhaps due to side effects, but we could argue that there are other reasons why patients seem to be more compliant with the beta 3s, although the compliance long term is overall not terrific with either set. The beta 3s seem to do a little bit better. And when you look at the antimuscarinics in terms of efficacy, lots of studies over the last 20 years suggesting again that as a class of agents, there's similar efficacy between these drugs overall. So I don't know that you could select one drug over another based on efficacy data, but there's some subtleties between the antimuscarinic agents with respect to drug-drug interactions and a number of other issues, cardiac issues and some things. But in terms of efficacy, I'm not sure you can select between the agents. And then you asked about individuals and drug selection for individuals. I think that all things being equal, the two classes of drugs work again similarly. So you can't choose one drug over another, in my estimation, for an individual patient based on efficacy. Now, patients come with comorbidities, and patients come with what Sarah talked about with constipation, and that might push you in one direction versus another. And they may have a list of drugs that would contraindicate antimuscarinics or increasing the antimuscarinic load. But in terms of picking a particular drug for a particular patient, other than patient comorbidities and patient preference, and even unfortunately their pharmacy plan, I don't know that we can predict in an individual patient how one drug will work. And at least in my practice, it is I will give them more than one drug in a class if they choose to continue with drug therapy, if they've not had an adequate response to one drug within a class. And there clearly are patients who will not respond to one drug, a beta 3 or an antimuscarinic in that same class, but you switch to another drug, and for whatever reason, pharmacogenomic reasons, perhaps things that we don't understand, they will respond to a second one. So I don't have a really good guidance on how to select an individual drug for an individual patient. Unfortunately, we're still in the trial and error phase with respect to that.
Right. I mean, I think unfortunately, a lot of the times it's the pharmacy plan that kind of helps make that decision, and not necessarily certain properties of the drug or specifics related to the patient. That being said, I do think there are certain patients where I'm absolutely going to go with the beta 3 first if I can, because of issues like, say, cognition. If you already are on the low road with the cognition, then I think the last thing I want to do is give an anticholinergic. And with Sarah's, we're back. We're urologists. We're back talking about poop again. But patients that have terrible constipation, and that's just a recipe for failure. I think when we give a medication like an anticholinergic that often causes constipation to begin with.
I agree 100%, but we also we forget when the original AUA guidelines came out, before there were beta 3s on the original AUA guidelines from 2012, the statement was made that we should not abandon antimuscarinic therapy for adverse effects until we try to treat the adverse effects. And sometimes at least, and I'm partly guilty as well, sometimes we're early to switch now to a beta 3 from an antimuscarinic without treating those adverse events. Because if the drug works well for the patient, but they, for example, have constipation, or they've got some other untoward effect, dry mouth, we're quick to switch to beta 3s. And one other comment, Dr. Chappell gave a terrific talk on combination therapy, and we forget how many drugs we have in this space other than antimuscarinics and beta 3s to treat filling and storage abnormalities in men and women. We have antimuscarinics and beta-3s, but we also have alpha blockers for men and 5-alpha reductase inhibitors and PDE5 inhibitors. And he gave a terrific talk on mixing and matching these with many studies showing combination therapy for antimuscarinics and beta-3s, but there's a myriad of studies looking at various combinations of these agents. And we shouldn't forget as clinicians that sometimes we can lower doses of antimuscarinics in combination with other agents. It allows us to reduce the antimuscarinic load, adding a second drug and using combination therapy for all of its favorable effects clinically. Of course, economically, that sometimes is disadvantageous, but from a clinical perspective, combination therapy amongst those 5 classes, sometimes we forget how many options we have in urology.
That's a great point. Eric, one last question for you regarding oral medications. I think one of the key elements of your course discusses setting proper expectations when communicating with patients regarding their OAB treatment and the potential need for further therapy or just expectations of their present therapy. So how would you counsel clinicians in terms of incorporating this into their practice when caring for overactive bladder patients?
It goes to what I spoke to earlier. The overactive bladder patient is they're not one monolith of a type of patient. They come with varying degrees of polypharmacy and different degrees of nocturia and comorbidities and as you stated earlier, cognition issues and even age. And patients also come with different expectations. We think, at least we're taught, that patients want to be cured, but by and large, when you actually look at patient expectations, it's not necessarily to be cured. It's to be better, and that was shown in the trial, in the NIH-sponsored trial published in New England Journal of Medicine, comparing antimuscarinics and Botox. Even though the cure rates in both of those groups, the antimuscarinic and Botox group, the cure rates were pretty abysmal, 20%, 25% in both arms, although slightly better with Botox than drug. Patient improvement was on the order of 50 to 60%. So clearly there are patients who get happy without being cured in this space. And Linda Brubaker had done some work on something called a Saga questionnaire, which is it's a self-assessment goal achievement questionnaire. That is, patients choose their own goal for pharmacotherapy, although Linda has used this same technique in pelvic organ prolapse and stress incontinence surgery and even IC. But the concept is that we ask the patient what they would like as their outcome. And some might say incontinence reduction, some may say reduction in nocturia, some might say reduction in urgency. And I think if you take that single question to the patient, you have almost more latitude to look at your therapeutic options to try to get your patient to reach their goal. And it might mean different drugs. It might mean an earlier transition to third-line therapies, or it might mean weight loss, or it might mean referral to a physical therapist. But asking the patient what their primary goal is, I think, important in treating overactive bladder. Sometimes you can lose the forest through the trees, I think, in this condition.
No, that's a great point, Eric. Just because a patient isn't perfect doesn't mean that he or she are not very, very happy and satisfied, and we don't need to escalate therapy or change therapy at all. It needs to be patient-driven. So, Sarah, two questions about overactive bladder therapy. Were there any other different or important conclusions during the debate that occurred on this during the SUFU session? And then, to me, I think really more importantly, when you see an uncomplicated, treatment-naive overactive bladder patient, and he or she's interested in pursuing pharmacologic therapy, how do you discuss the options of starting anticholinergics versus a beta-3 agonist with that patient, and how do decisions get made?
So this is referring to the debate about anticholinergics or antimuscarinics versus beta-3 agonists with Dr. Griebling and Dr. Chancellor. The problem is this is kind of a tough controversy. We're essentially, the way I describe it is we're comparing old apples to fresh oranges. Even though the beta-3 agonists were first approved in 2012, we just don't have the ability to resolve this imbalance of power between these two medications, because one class is so much more readily available than the more expensive beta-3 agonists, to many of our dismay. The take-home points that I would say that they made is that antimuscarinics are more readily available, not as cost prohibitive as compared to the beta-3 agonists. However, there is that higher side effect profile in many patients, and we've talked about a lot of those issues: cognition, constipation, dry mouth, which triggers a whole nother set of compensatory reactions when they're taking those medications. But the beta-3 agonists themselves do have side effects, but different, and really seem to be cost prohibitive depending on where you are and what payer mix you have for insurance. So when I have a patient sitting in front of me about this, I really talk to them about who they live with, any history of falls. I just want to make sure that I'm not exacerbating or causing a safety issue if I'm trying an anticholinergic. And if they are going to have a safety issue that I can identify, I just document that and say that it's medically contraindicated for that patient. And sometimes I'm able then to move on to beta-3 agonists if it's not first-line treatment on their payer plan. So again, your case that we kind of have, if it's a 60-year-old naive, treatment naive overactive bladder patient, I really look at those factors about where they are on their cognition spectrum, and what sort of, how are they going to be handling the side effects of potentially of the medication. I also take that opportunity when I'm going to start a medication to go back and review their adherence to first line treatments, and introduce that there are these two possible medications that we could start. The other thing, insurance is really different across the country, and what's available. Some insurance companies will require an anticholinergic trial first, and so then I have them report back with efficacy and side effects. If I do have to try an anticholinergic, I try to do definitely once a day dosing, not immediate release dosing formulations. And then if I can, I try the quaternary amine that's available, which is trospium, extended release, but oftentimes that I find that's cost prohibitive too. The other thing for women, like if this patient that hasn't started medication but is just on behavioral therapy, the other thing for women is I always probably will start at that point, or have previously started vaginal estrogen treatment, because it's really not uncommon that a lot of these women postmenopausal have vulvovaginal atrophy, and overactive bladder is one of their symptoms presenting with that. And so I mean, I have to say, if I start first line therapies of behavioral therapy, maybe some pelvic floor physical therapy, and vaginal atrophy, and maybe some leg elevation for first line treatment, I'll have a lot of women come back and say they're greater than 50% improved just with that combination of treatments. And so recognizing that their quality of life can be so much better with treatment of vulvovaginal atrophy and their bladder symptoms is really important before moving along to those next line treatments.
Great, thank you. So Eric, your course also discussed therapies, future therapies for overactive bladder. Any thoughts regarding the late-breaking abstract that Dr. Ken Peters presented on Friday that looked at gene therapy to treat overactive bladder?
Yeah, really interesting. David, the holy grail remains uroselectivity. That is, getting a drug that only works in the urinary tract and not have collateral effects elsewhere. There are no new antimuscarinics in development. The two beta-3s that were in development, ribegron and salabegron, are no longer in development. There's no published phase 3. And all the other drugs or drugs in development, different pathways, P2X3s and TRP antagonists, NK1s, they haven't progressed very well. But what is new is what appears to be gene therapy for overactive bladder. And this was an abstract presented by Ken Peters on Friday at this meeting. And in essence, what this gene therapy is, it's a plasmid vector which expresses the alpha subunit of the BK channel, the potassium channel on smooth muscle cells. And if you increase the activity of the BK channel, which presumably by injecting this plasmid vector with an alpha subunit into the bladder wall, you're increasing the activity of the BK channel, the large conductance potassium channel. And that increases potassium efflux from the cell, which hyperpolarizes the cell and relaxes the cell, causes smooth muscle relaxation. And Georgi Petkov and others have looked at the BK channel and its effects on overactive bladder. But this data was 12-week data in a small number of patients, 74 patients. They were randomized to placebo and 2 doses of this plasmid vector. And this is the 12-week data that was presented. And it was actually, David, it was actually pretty impressive. The both doses, low and high dose, were significantly improved urinary frequency versus placebo. The high dose significantly improved urgency versus placebo, and both numerically improved urgency incontinence versus placebo, although it wasn't statistically significant. But and the AEs, the adverse events, were minimal, with one person with an increased post-void residual. So very well tolerated. So I would say that the numerical changes, if you use Dr. Wien's placebo ratio, was actually twice the response that we see with drug. And admittedly, it was a small number of patients, and admittedly a short-term study. But I think this is this could be, if duplicated in larger numbers of patients and substantiated, that this could be a new avenue for therapy for overactive bladder in patients, which is uroselective.
That's fantastic. Yeah, this is it's pretty exciting for us to have something that would be a gene therapy and be very, very uroselective. So let's move on to refractory overactive bladder and talk about third-tier therapeutic options. Dr. Cameron, you're faculty for the complex voiding dysfunction course. I'm involved with refractory overactive bladder course, both instructional courses that discuss therapy for refractory overactive bladder. I think part of the challenge is picking the right therapy for the right patient. We have 3 options: tibial nerve stimulation, botulinum toxin, and sacral neuromodulation. So Dr. Cameron, just a few questions about tibial nerve, pros and cons, patients that are best for this, patients you avoid, any tips or tricks to optimize doing it in the office, and any comments on some of the newer therapies that are available to us now or under investigation.
Yes, thank you. So PTNS is minimally invasive therapy. There is little to no risk other than some local ankle symptoms of minor bruising or soreness. So that's very appealing to patients. Many patients are risk averse, and they really don't want to place themselves at risk. They don't want to go to the operating room, and they don't want to run the risk of urinary retention. So this has none of those side effects. The downside is patients who have pacemakers are not eligible for this therapy. It's a contraindication, but there are otherwise not many specific contraindications that are commonly occurring. But those people where the treatment would be cost prohibitive, and that would be people who have to travel for a very long distance. I live in Michigan. If you have to drive for 4 hours to get your therapy, which is a half an hour once a week times 12 weeks, and then maintenance therapy, that might not be realistic for you. But people who have good transportation or can easily make it to your clinic, it can be a great option. Again, patients who are understanding of this therapy, I try to explain it that it's similar to taking an oral agent. You have to continue with the therapy. There's a misconception, and many patients stop after 12 weeks because they're better, and then they lose their efficacy, and that's because they haven't stayed with maintenance therapy. So I try to create an analogy that it's similar to taking a medication. You have to continue with your therapy to get the benefit. The other thing you have to discuss with your patient is that they're not going to get benefit on the first day. They can't give up after one treatment. We do see some treatment benefits at 6 weeks, but you really have to make it to 12 weeks to fully assess the therapy. So you have to tell people to exercise patience and not give up. So people who need to be better sooner, that might not be a good option for them. People who live far away, people who don't understand the therapy, and people who really don't want to take time out of their day to do it are probably poor candidates for that.
Great, thank you. In terms of your office, who does this in your office?
So in our offices, we have advanced practice providers, PAs and nurse practitioners who, a select group of those. So we have a group of not all of the APPs in our urology department, but those who are with our division, who are all experts in overactive bladder. So these are the same advanced practice providers who help our sacral neuromodulation patients. They see overactive bladder patients routinely. So they are knowledgeable about the full spectrum of overactive bladder. And so they do the needle placement. And again, these patients often have questions. They have issues that come up in between. And so I think these are a great resource to do that. And we run tibial nerve stimulation clinic at the same time as regular clinic, and patients can get this therapy more conveniently because this is a large burden for them. I know you'd asked as well about the advanced therapies. I think that this is really amazing work that's being done. There are multiple devices that are either FDA approved or are in the process of going through FDA approval. And I think the initial data that was presented at this meeting with some posters and podium sessions has been very favorable. Again, that location in the body is fairly low risk, and it eliminates the inconvenience of the tibial nerve stimulation. And many of these are being trialed as an office procedure under local anesthetic. So your patient who is not a candidate for the OR or simply does not want to go to the OR. There are many people who are healthy but do not want an anesthetic for various reasons. So I think that this is really encouraging work, and I think something minimally invasive and very effective is extremely promising. And I think to me as a human being, this sounds very appealing.
Great, thank you, Ann. So Eric, let's move on to botulinum toxin. So similar questions: pros and cons of botulinum toxin for refractory overactive bladder. Patients you think are good candidates, patients you think may be suboptimal candidates for this. Any tips or tricks in optimizing this in the office?
Yeah, quickly just go over a couple of these. So, you know, the pros of the therapy is that it works well. It works in the vast majority of people. It's fast and it's easy to do. We're very comfortable as urologists doing endoscopy. The cons are really, the biggest con is really is the need for repeat injections, and whether that injection is at 4 months or 6 months or 9 months or even 12 months. You need repeated injections. So it's not a one-time fix. And then, of course, the other cons are risk of retention and adverse effects such as recurrent urinary tract infections. With respect to patients in whom I wouldn't use Botox, clearly patients who are unwilling or unable to catheterize, that those patients are excluded from Botox. Patients who are unwilling to come back for repeat therapy. I think if we counsel our patients appropriately up front and we ask them, are you willing to come back every 6 months or 4 months or 9 months? And they say no, then they're not a candidate for the therapy. And then some more subtle things: patients with elevated post-void residuals, or patients in whom I've done urodynamics on, and that certainly is not, I don't do urodynamics on every patient that I'm about to do Botox in, but in those who I do urodynamics and they've got poor contractility, they need to be counseled that, again, their risk of going into retention or needing a catheter either temporarily or reasonably long period of time is high. And if they're unwilling to do that, again, I counsel them against Botox. And then the last group is probably the ones that are most controversial. I think deep down that if somebody's obstructed and we Botox them, they have a higher risk of retention. So I counsel them against Botox, but I'm not sure that that's true. I think it's true, but I don't know. So somebody who's obstructed, or I think is obstructed, I'll counsel against Botox. Just to give SUFU a plug, there was a great abstract presented this morning from the SUFU research group looking at transvaginal Botox injection, and preliminary data on a small number of patients looks pretty good. But the point is that patients tolerated it really well. And for those patients who are somewhat skittish about a cystoscopic examination, this might be an alternative approach, although again, preliminary data, small number of patients presented at this meeting from the SUFU research group. So transvaginal injection might be the way to go in the future. Who knows? Clearly, we need better studies. And then, in terms of Botox efficiency in the office, or how do you optimize the use of this therapy, I think it's your office staff, and that is the staff have to be comfortable setting the procedure up, taking the procedure down, scheduling in your office multiple Botox injections in the same day. I find to be incredibly efficient, as opposed to scheduling one in the middle of office hours. Schedule them throughout so the staff becomes very familiar with the procedure itself, and have a nurse who's a specialist in injections, so they're comfortable with the setup and how the patients react to the therapy. And then finally, my last tip is I have a rigid scope in my office that I use for females. It makes the procedure much shorter. It allows me to do the procedure myself without any assistance. So I like using a rigid scope in females. I use a flexible scope in males. And again, setting up multiple injections in a day and then having a templated note for your electronic medical records for Botox makes that post-Botox injection period where you're on the computer much shorter if you've templated everything, because the procedure really is perfect for templating.
Yeah, and it's the same thing every time. And I like to borrow your rigid scope because we just have flexible scopes in our office. So that would be nice to have. You saved one. That was smart. All right. So, Sarah, let's finish up talking about sacral neuromodulation. And again, similar questions, the pros and cons, patients you think are best for this therapy, patients you want to maybe avoid this therapy on, and anything that you do in the office to optimize it. I know there are clinicians that are concerned about their lack of comfort with programming and dealing with sacral neuromodulation.
So sacral neuromodulation really is, provides continuous neurostimulation therapy. And so this can be an advantage over the PT&S treatment. And it's really successful for motivated patients. They determine what programs they like, they modify as needed. So the patients that I find the benefit are those, the pros are that we can do it for patients that have imperfect bladder emptying, like the ones that Eric is mentioning. So oftentimes this, for me nowadays, are MS patients with detrusor overactivity but incomplete emptying. The other pro is that there's no risk of urinary tract infection. So a lot of our female patients are already having overactive bladder and oftentimes have recurrent infections, or that one infection that was terrible, and they don't want to have that experience again. And so there's no risk of urinary tract infections with trying sacral neuromodulation, and also no risk of retention. And as we know, it's FDA approved for 3 indications: overactive bladder, fecal incontinence, and non-obstructive urinary retention. So sometimes those patients actually bundle into all one patient, and sacral neuromodulation can be great for them. The cons are that it requires a small surgery to place, and depending on your practice, if you're doing PNEs in the clinic to trial it, there's just one surgery then in the operating room, or there might be a staged procedure. But you have that, the benefit is you have that trial period, so you're not committed. We do have rechargeable devices available by multiple companies now, and also long-term batteries that require can be implanted for a long time and not necessarily need to be replaced potentially ever. But the cons overall, though, is it can require some maintenance to get really sustained efficacy. And so this can be frustrating for patients, and I think really gets to patient selection. So patient engagement and how technically savvy they are. I have them tell me if they can program a new contact into their cell phone as my screening question to make sure that I think that they can actually handle managing the device. I also, if they can't do that, then I try to go towards PTNS with maintenance therapy or Botox if they really qualify. I also avoid the therapy on chronic generalized pain patients and then chronic back pain patients. They really are not. They tend to be bothered by having that metal device in their body one way or another. They're still going to blame it on their back pain or something like that. And generalized pain patients just are very triggered by a foreign body in them. For the maintenance in the office, I know that there are many generations of providers out there that are offering this treatment. First of all, I think the companies that are developing the devices have really done a good job at recognizing that honestly, the success of their device is dependent on their customer service. And they need to have some ability to do some troubleshooting for patients. And so them being able to call in and take over and do a Zoom call on the newer devices, I think is a big win for helping patient satisfaction and persistence with the therapy. Right now, I have an excellent rep that I can call and she can coach me through tips and tricks that I don't yet know. But that being said, I think that, it's our job to really help give a good name to this type of therapy. And as a provider, we should be at least basically proficient at doing some troubleshooting, some basic troubleshooting in the clinic. And just like we shouldn't expect the patient to set it and forget it, we shouldn't necessarily expect to just set it and forget it and have it run forever also. So, I definitely encourage providers and my residents to get some basic training so they can help troubleshoot this and be proficient with it. The other aspect of troubleshooting is really to consider whether the lead was ever or still is in the correct location. And so I have a pretty low threshold to go ahead and get a plain x-ray of the pelvis, 2 views, so PA and lateral, to just check where the lead is and make sure it's where it was when it was placed. If I didn't place it, I kind of look at the placement and wonder if it actually was in a good location to begin with. So I think that it's our job to really try to not have this type of therapy get dismissed because of the difficulties with troubleshooting when providers place the devices and don't necessarily know how to treat them. I don't have a nurse champion who can troubleshoot this, but there are courses available, and many practices I know have nurse champions and APP champions that are really, really good at doing this. And so just having somebody who can manage that in your practice is really going to be beneficial to have it be a win in your practice.
Thanks, Sarah. Those are all important points. And I think even for those, and I agree with you, it's good to be able to understand how to work the programmer. But as a clinician, if you still are not comfortable, I promise you that your reps will be, if they will come and program for you. And what we'll do is, what people will do is just say, okay, I'm going to have 5 of my SNS patients in today and have the rep come and go through all of them. And that's a great way to do it. And I think I'm going to guess the attendees didn't know that one of the take homes from the OAB course was to talk to your patients about their bowel habits over and over. Because to Sarah's point, if a patient has overactive bladder that's refractory and they have fecal incontinence, you should be giving them sacral neuromodulation because you're theoretically going to potentially treat both. And that's an important one. So before I wrap up, anyone have anything else to add on the 3rd tier therapies? I think you all did an amazing job and a wonderful job kind of talking about that. Any other tips and tricks anyone else wanted to add to that?
So one thing that I find important, because many patients would be eligible for any of these therapies, patients who are refractory to oral agents. There are many patients that there's nothing swaying you in one direction or the other. And then you really need to focus on patient-centered care and shared decision-making and really present the patient with their options that are available to them and say, what matters to you? Because patients often have very strong opinions. I do not want a cystoscopic procedure, or I do not want a foreign material, or I don't have time to come into your office. And that should really be the center and the beginning of your follow-up discussion, because you only want to offer them things that are going to work within their life and their lifestyle. So I think barring a contraindication, I think you really need to often start that discussion of what's most important to you.
Perfect. I agree with that completely. But whatever we do first, I also tell the patients these options are not mutually exclusive. If you fail one, unless there's a contraindication, the other two will always be available to make sure they realize. I think that's important with the counseling. So Eric and Sarah, thank you so much for your time today to discuss this very important and timely topic. You did a really nice job touching on some very important points, including the evaluation of patients with suspected overactive bladder, the use of both behavioral and pelvic floor physical therapy, how to optimize the use of oral pharmacotherapy, the importance of managing expectations in regard to improving versus just curing, improving the patient's overactive bladder symptoms, and a really nice and thorough discussion of the third tier therapeutic options for overactive bladder and how these can be optimally implemented in a clinical practice. Thank you very much.
Thank you.
Thanks.
Thank you.